Nida Khan. She is presenting for semi-final session. Her topic is efficacy of adalimumab in non-infectious uveitis, a study at Tertiary Care Center in South India.
Good morning, everyone. I will be presenting on efficacy of adalimumab in non-infectious uveitis. Uveitis accounts for nearly 10 to 25% cases of legal blindness in developing countries. Resistance to conventional therapy, drug-related adverse effects pose a significant barrier. Biologics have been a useful substitute for treating these cases. Adalimumab is a fully humanized recombinant monoclonal antibody which is directed against TNF-alpha. In July 2016, adalimumab got the first and became the first and only biologic approved by the FDA after the two trials, Visual 1 and 2, which was followed by Visual 3 study. However, in a country like India, the use of biologic agents is feared to be more prone to developing infections. We conducted this study to describe the treatment outcomes of adalimumab in non-infectious uveitis. It was a retrospective observational study conducted between 2017 and 2023. Electronic medical records of all non-infectious uveitis patients who received adalimumab were analyzed. Patients with infectious uveitis and a follow-up duration of less than 6 months were excluded from the study. The indication were inadequate response to immunotherapy, intolerance to immunotherapy, and for control of primary systemic disease. The criteria for treatment success was control of inflammation, significant decrease in disease recurrence, vision improvement, and vision stabilization. Appropriate investigations were done wherever required. Non-response to immunosuppressive was regarded as deterioration or persistent inflammation for 3 months with the use of immunosuppressive. A decision to administer adalimumab after was decided either as first-line therapy or after non-response to immunosuppressive was made after consultation with rheumatologists, but primarily at the discretion of ophthalmologist. Appropriate statistical tests were applied, and p-value of less than 0.05 was taken as statistically significant. To the best of our knowledge, this is the largest study involving adalimumab in India conducted, involving 43 eyes of 26 patients with 12 males and with 14 males and 12 females. The mean age at adalimumab treatment was 18 years, and the mean age at diagnosis of uveitis was 14 years. Anterior uveitis were diagnosed in 11 eyes, intermediate in 5, anterior with intermediate in 12, and pan-uveitis in 11 eyes. The mean duration of follow-up was 19 months. Only 4 patients received the first-line therapy, while other patients already had received some immunosuppressive therapy. The most common diagnosis was JIA, followed by BASITS, VKH, and the least common was Crohn's. The course of uveitis was complicated by various complications in these patients, including posterior synecdoche, cataract, BSK, CNVM, CME, RD. Nearly 23% eyes required some surgical intervention due to these pre-existing complications. Adalimumab monotherapy was considered in only 1 patient. Oral steroids could be stopped in 12 patients, and oral steroid dose was reduced to 2.5 milligram per day in 8 patients. Disease inactivity was achieved in 97.7% of the eye at last visit, and remission was achieved in 32 eyes at 3rd month. BCVA improved from 0.45 to 0.24, which was statistically significant. Overall, vision was improved in 21 eyes. It remained same in 16 eyes and worsened in 6 eyes. Drug had to be discontinued in 1 patient due to financial constraint, and relapse was seen in 2 patients. No systemic or adverse reaction was observed during our study, and only 1 patient developed some raised liver enzyme due to concurrent methotrexate therapy. This is a photograph of one of our patients showing before and after treatment with adalimumab. The management of non-infectious uveitis is a dynamic field. Effectiveness of adalimumab in JIE-associated uveitis has been well demonstrated by Sycamore and Adjuvant trial. Accessibility and affordability of biologic therapies in a resource-limited country like India remains a challenge, limiting their use. Likewise, in one of our patients, the treatment could not be continued due to financial constraint, and he had to be shifted to oral methotrexate. The EULAR has given anti-TNF-alpha as the first line for BASITS-associated uveitis. In our series, 3 patients with BASITS responded very well. In our series, 1 pediatric patient with Crohn's disease required adalimumab. None of the patients in our study developed some new complications. Although adalimumab has a lower rate of recurrence, but relapse can still occur. In our study, relapse was seen in only 2 patients. Our study had certain limitation. It has a small sample size. However, ours is a tertiary referral eye care center that often caters difficult to treat patients with uveitis, frequently presenting late in the course of disease. And the mean duration of uveitis from symptom onset to presentation was 46 months. Quantitative evaluation of inflammation was not done in our study. To conclude, adalimumab was found to be effective in the treatment of non-infectious uveitis by achieving uveitis remission, reduction in recurrence rate, with subsequent improvement in best-corrected visual acuity. The drug is safe and well-tolerated as we did not encounter any systemic infection. It has a corticosteroid-sparing effect. Thank you.
What is the cost and how many days you prescribe the drugs?
I think 6,000 per dose it is.
Right. Okay, so very nicely presented, but one of the main caveats when we treat with any of the biologics is that it is not sure shot that 100% of your patients will respond. So with adalimumab, the ratio of patient is 70 is to 30, that 70% of the patient respond and 30% patient just do not respond because their cell lines which are affected by adalimumab are not the ones which are responsible for causation of the disease. But in your case, it appears that all 42 patients?
Yeah, 42 eyes, yeah.
All 42 responded very well. So how do you explain that? You did not have to switch between the biologics in any of the cases?
Sir, most of the patients, most of them were already treated with some or the other immunosuppressive therapy.
No, I'm not talking of immunosuppressive. See,
yeah.
So
97% we got at the last visit. So it was the 97% at the last visit. That was the one. And at the third month we saw the remission. It was 74% patients.
Yeah,
the remission was achieved in 74% patient at third month. That is what I told.
74%.
Yeah.
So that part one has to be, the message should be very clear that adalimumab is not a panacea for all uveitis. It is for a subset of patients, and still when you treat with adalimumab, few patients will be met with failure, and when you see a patient with failure, switch to another biological.
Okay, how many days you given treatment for remission for this?
How many?
What are the doses and how many days duration?
Sir, it was different for different patients. Actually, I've also mentioned the average number of injections which we gave. I'm unable to recollect. It's mentioned in one of my slides actually. But it was when the patient was responding well, we increased the gap between, like we started with 2 weeks interval, but when the response was good, we with the consultation with rheumatologist, we made it 3 weeks or 4 weeks gap, reducing it.
Okay.
When you decide that you have to start adalimumab?
Like non-response to immunosuppressive therapy after 3 months of duration and persistence of inflammation, then we shifted the patients to adalimumab.
And about the treatment, like
including steroids plus and other immunosuppressives like azathioprine or methotrexate.